Hey everyone, welcome back. You're diving into part 30 of our massive 100-part CPC exam series. Today, it's all about the respiratory system, and I am absolutely pumped to guide you through all the tricky little traps APC loves to hide in this section of the exam. Before we take that first breath of new material, I've got to ask you to do one quick thing. Make sure to like, share, and subscribe to Decode Healthcare with Harshal. It seriously helps us build this awesome community of focused learners, and honestly, it keeps this whole series going strong. All right, let's look at our airway descent map for this explainer. We're literally traveling from top to bottom, starting at the nose and sinuses, heading down through the larynx and bronchi, and finally landing in the lungs. We'll be pointing out exam traps at every single stop. So starting off with Section 1, the Respiratory CPT Blueprint, covering codes 30,000 through 32,999. You know what's kind of cool about this? The CPT manual is actually super logical here. The surgery section for the respiratory system is organized strictly by anatomy. You literally just follow the air. You start at the nose and accessory sinuses, move down to the larynx, into the trachea and bronchi, and finally reach the lungs and pleura. Getting this top-down flow locked into your brain, it is a massive time saver when you're furiously flipping through your book on exam day. Moving right along to Section 2, let's talk nasal and sinus endoscopy guidelines, looking at codes 31231 through 31298. Listen up, because AAPC loves to set a massive bundling trap right here. You've got to know the difference between diagnostic and surgical endoscopies. Here is your golden rule. Diagnostic nasal endoscopy is always, and I mean always, included in a surgical sinus endoscopy on the same side. If the surgeon goes in to just take a look, but then decides to make a cut or do a surgical intervention in that exact same session and anatomic area, do not build the diagnostic code separately. The surgical code just eats it up, it absorbs all that work. And that brings us to modifier 50. Burn this number into your brain. A lot of nasal endoscopy codes are inherently unilateral, which just means they only account for one side of the nose. So you have to read that code descriptor incredibly closely. If they did the procedure bilaterally, meaning on both sides, boom, you have to slap on modifier 50 to make sure you get the proper reimbursement. Heading further down the airway now, we hit Section 3, Laryngoscopy Rules, covering codes 31505 to 31579. The exam absolutely loves testing if you can spot the approach here. First, you've got direct versus indirect. Now, an indirect laryngoscopy is where the provider uses a little mirror to look down the throat. It's way less invasive. But a direct laryngoscopy, that's a direct line of sight visualization using a rigid or flexible scope. When you're reading an operative note, grab your highlighter and mark direct or indirect the second you see it, because it completely changes which code family you're in. You also want to keep your eyes peeled for any mention of an operating microscope or telescope. Some of these standard laryngoscopy codes bundle the visualization right in, but others specifically include or exclude the scope in their code descriptions. Spotting that one tiny detail, that's going to help you cross out the wrong multiple choice answers in a heartbeat. All right, down into the bronchi we go. Section 4 is bronchoscopy guidelines and bundling, covering codes 31622 to 31661. These codes show up on the test all the time, so stay with me here. Remember that bundling rule we talked about for the nose? Well, it's back. CPT code 31622 is your diagnostic bronchoscopy. If you do that diagnostic scope and it turns into a surgical procedure in the exact same session, yep, the diagnostic work is bundled. You only report the surgical bronchoscopy. Don't let the exam trick you into unbundling those. Now, what happens when a provider performs multiple endobronchial procedures through the same scope? Things like a bronchial biopsy, washings, or bronchoalveolar lavage, which you'll often see written as BAL. Well, you've got to follow specific CPT parenthetical rules. Coding these all depends heavily on whether the procedures were done in a single lobe or spread across multiple lobes of the lung. So always verify the exact anatomy in the clinical note. We've reached the bottom of the airway. Section 5, lungs, pleura, and vats, focusing right on that lower respiratory tract. Let's take a look at thoracentesis, which is draining fluid from the pleural space. This is a classic exam scenario where one single detail changes everything. Code 32554 is for doing it without any imaging guidance. But code 32555 is performed with ultrasound or CT guidance. Literally just checking the note to see if an imaging machine was in the room instantly hands you the correct code. Next up, we need to compare VATS. That stands for Video Assisted Thoracic Surgery. with an open thoracotomy. VATS is minimally invasive. They're just using a scope. An open thoracotomy, though, that involves a major incision to physically open up the chest. And knowing the difference between those two sets up one of the most critical rules in the entire surgery section. We call it the conversion rule. If a surgeon starts a minimally invasive VATS procedure, but things get complicated and they have to convert it to an open thoracotomy, you never code both. Never. You only code the successful open procedure. All that scope work just gets bundled right into the major open surgery. Which brings us to Section 6, the respiratory cheat sheet, where we wrap up our summary and key takeaways. So here is your one-page visual summary for the 30,000 to 32,999 CPT range. It's got the diagnostic bundling rule, the unilateral modifier 50 checks, the laryngoscopy differences, and that super important VATS conversion rule. I'd highly recommend you pause this explainer right now, take a screenshot, and keep this summary handy while you study for the exam. You guys seriously crushed it today. But before I let you go, I want you to think about this. How many thousands of dollars do you think are lost in miscoded claims every single day just because a coder missed a tiny surgical conversion in an operative note? Attention to detail isn't just important, it is literally everything in this field. Are you ready to take that kind of laser focus into the cardiovascular system? In Part 31, we're tackling pacemakers, CABG, and angioplasty. Make sure you're subscribed so you don't miss it, and I'll catch you in the next explainer.